let's get started. This is one of the last hot topics we have for the TCTAP. This is going to be about TAVR, current status and future perspective. I'm Alan Yeung. I'm together with Jung-Woo Park. We have an esteemed panel. We have Dr. Buddhari, Dr. Fang, Dr. Hayashida, Dr. Kim, Dr. Lee, and Palmerini, Dr. Poon, and Shirai, and Dr. Yuda. So without further delay, I'm going to hear from David Cohen about the cerebral embolic protection in TAVR, obviously the latest data that we have just been hearing. So, David?
Thank you very much, Alan. It's really a pleasure to be here and to continue to cover the saga of cerebral embolic protection. And I'm going to focus on the recent randomized trials today. These are my disclosures. So we know that stroke is still one of the most devastating complications of TAVR and one that we all would like to avoid. And despite all the iteration and procedural refinement, stroke after TAVR in large registries is pretty stable, right around the 2%, maybe up to 3% range, depending on the particular study. We also know that cerebral embolic protection devices capture debris in almost all TAVR procedures, and at least in one study have been shown to reduce the number of new brain lesions. But it's unclear whether these mechanistic effects result in clinical benefits. So I'm going to cover three issues. I'm going to talk about really what is the problem of stroke in 2025, what we've learned from the clinical trials, and then I'm going to come back and try to give some speculation about why we don't see benefit today. So is stroke still a problem? Yes, it is. This is the data from the TVT registry ending in 2020, but the pattern has largely continued. The in-hospital stroke rate is somewhere between 1% and 2%. The 30-day stroke rate after TAVR is somewhere between 2% and 3%. And so it certainly still is an issue, especially considering this, which is what happens after these patients undergoing TAVR have a stroke. You can see that there is an excess mortality that carries all the way out to 5 years. They spend fewer days at home, and the cost is about $9,000 per excess stroke. So what have we learned from the clinical trials? We are blessed because we do have clinical trials, and I think when we have them, we need to pay attention to what they show and try to understand their results. So there are, in terms of the Sentinel device, which is the one that is approved in the United States and the one that is most available worldwide, there are 4 randomized trials that have been done. And I'm going to focus on the 2 large ones, the PROTECTED-TAVR trial, which was a US and Europe trial, and then the PROTECT-TAVI trial, which was the most recent one just presented at the ACC, which is a UK trial. So the PROTECTED-TAVR trial took 3,000 all-comers patients undergoing a transfemoral TAVR. It had a neurologic exam pre-procedure, then they were randomized to TAVR in a standard fashion or with the Sentinel device, and all patients had neurologic exam post-procedure. So it was really trying to focus in on clinically relevant strokes, and the primary endpoint was stroke at 72 hours or discharge, whichever came first. The primary endpoint was neutral. There was a trend, a 0.6% absolute risk reduction, but it was not at all statistically significant. However, when one looked at a number of pre-specified secondary endpoints, there was this intriguing signal of a reduction in disabling stroke with no effect at all, in fact, a little bit of excess on the non-disabling stroke side. Importantly, no difference in mortality or acute kidney injury. The more recent trial, the BHF-PROTECT-TAVI trial, was even larger. So this was a trial of over 7,600 patients, and ultimately 7,594 patients underwent TAVI, randomized again to the Sentinel or no embolic protection. Importantly, it was originally supposed to be about a 5,400 patient trial. The DSMB recommended increasing it to 9,700 patients due to lower than expected event rates, but the enrollment was actually stopped at an interim analysis because of futility. It was not ever going to make its primary endpoint. And again, very importantly, this trial was really all comers. It enrolled more than 30% of all the patients who underwent TAVI in the UK during the time period that they were enrolling. The primary endpoint was similar to the PROTECTED-TAVR trial, any stroke within 72 hours, and was powered to find a 33% reduction in stroke. And what they found was disappointing. They found absolutely no difference in stroke. They had a little different neurologic assessment. It was a little bit less compulsive than what was done in PROTECT TAVR, but it was unbiased using a validated method, and there was no difference whatsoever in stroke. And again, when they looked at pre-specified secondary endpoints, in this case, there was no difference whatsoever, despite it being more than twice as large in disabling stroke, death or stroke. It couldn't have been a more neutral trial if you can possibly imagine. In terms of subgroup analyses, there is some variation, which is normal, but they really all do pretty much line up. All the confidence intervals cross the unity line. The only group that there seems to be maybe a benefit is in this very tiny group that represents about 2% of the patients randomized in the trial of high-risk patients. But again, even there, the confidence interval crosses 1. And so there is no consistent subgroup of patients that benefited that they could find. One very important aspect that has been brought out from this trial is it was a very pragmatic trial. And what that means is the enrollment criteria were the doctor thought they could do an embolic protection device with the Sentinel. It ended up that about 87% of the patients had the device introduced and some protection performed, but only 81% of the patients had full protection during the entire procedure. That is, both limbs of the embolic protection filter deployed left in place for the entire duration of the procedure. And that's been raised as a question. Is that a fatal flaw, if you will, in this study? And what they did is this very specific type of analysis called a CASE, a Complier Average Causal Effect Analysis, which is a little bit, it is a better way of doing the typical as treated or per protocol analysis, because this one respects the randomization, so it doesn't violate the randomization. And what they saw here was, again, these are the differences, the absolute benefit of CEPD, and you can see it does go up a little bit when you adjust for the lack of full use of the embolic protection device, but it never achieves anything close to statistical significance, only trivial changes. So now to summarize what we know about Sentinel, at least, in patients undergoing TAVR or TAVI. We have one positive trial, that's the Clean TAVI trial, which was a single-center study using an imaging endpoint. The Sentinel trial in the United States, which is what led to its approval, had an imaging endpoint which was neutral. PROTECTED-TAVR had a clinical endpoint which was neutral. BHF-PROTECT-TAVI had a clinical endpoint which was neutral. More than 10,000 patients randomized, and except for a small 100-patient trial, everything is neutral. So is the device safe? Yes, absolutely it's safe. Is it effective? It doesn't seem like it. I think, again, to my view, this is 3 strikes and you're out. So the question at this point is, why doesn't it work? Because we see material in the filter in the vast majority of cases. And I think there are 4 potential reasons, and these have important implications both for other devices as well as for trials. Maybe it's a device issue. Maybe the pores are too large. They're 140 micron. We do have incomplete vessel coverage. We only cover 3 out of the 4 great vessels. And so the solution to this problem, if that's what the issue is better devices. Devices that have smaller pores and cover all the vessels. There may well be unintended consequences, and I do think this is an issue with the Sentinel device. Because you see material in the basket in almost all cases, that suggests to me that the device, if there's no benefit, the device is probably causing as many strokes as it prevents. And that's a problem that can't be overcome by bigger numbers. We need better devices that can be used more safely that don't cause excess events. In addition, it's possible that the effect size is smaller than hypothesized, resulting in underpowered trials. We've done work in the TVT registry with 400,000 patients, suggesting that at least with this device, the absolute risk reduction or the relative risk reduction is about a 10% absolute risk reduction, and that means your trials need to be 100,000 patients in order to find a benefit, which maybe means you shouldn't be doing these trials to begin with. And finally, I do think there is a possibility that we've been studying the wrong endpoint, that looking at all stroke is not the right way to go, because I do think that if there is any benefit of these devices, it's probably converting large strokes to smaller strokes. And that might be masked just by the trial design, and maybe disabling stroke ought to really be the clinical endpoint, although there, the sample sizes start to get even larger. So to summarize, stroke remains a significant and unpredictable complication after TAVR. Our current embolic protection devices, in particular the Sentinel, definitely captures procedure-related debris and may reduce the volume of new brain lesions, but the clinical benefit is distinctly uncertain. And if present with this device, it seems to be limited to disabling stroke and very small, with the number needed to treat probably around 800. So think about that. If you have a 200 TAVI center, it's going to take you 4 years to prevent a stroke. It's been difficult to identify subgroups with consistent benefit, even though we know certain subgroups have higher stroke rates. And I would say my main conclusion is we need newer devices. These should undergo rigorous evaluation, ideally for stroke prevention rather than surrogate endpoints, but surrogate endpoints will certainly be important for approval. Thank you very much.
So David, will you be around after? Okay, thank you. Next is we're going to talk about bicuspid TAVR. Jung-Min is going to talk about all the technical issues and data from the Asan Medical Center.
Thank you, Alan. My topic is bicuspid TAVR. The first TAVR was done in the patient with the bicuspid, but many randomized trials, but bicuspid was excluded in the protocols. But nowadays, even in the low-risk trial, the TAVR showed a better survival, even survivors. Recently, Partner 3 trial, 5-year outcomes. Another randomized trial showed that the TAVR better than SAVR, even regarding the death from any cause. But look at the mean age. This is the trial, the mean age is 74. Previously, initial TAVR randomized trial, mean age was 83 or 84. So nowadays, TAVR patient age is getting younger and younger. So we met more frequently, we met the bicuspid patient. So this is Alan Cleaviage's slide 9 years ago. So he thought that in 2016, TAVR is indicated in patients who are not optimal candidate to surgery, but maybe 4 years later, the TAVR is indicated in patients who are not optimal candidate to TAVR. So it will be the bicuspid. So there are lots of clinical and anatomical challenges. For example, this is our data, show that compared with the tricuspid, bicuspid patient younger and more male. Tricuspid patient usually female dominant, but the bicuspid is male dominant and younger. So less comorbidity. So we need a more optimized result. We have to think about lifetime management, and valve longevity is important in bicuspid treatment. In addition, hemodynamically, bicuspid is a more severe aortic stenosis. Ejection fraction is normal, but the trans Vmax is higher, peak gradient is higher, effective orifice area is smaller. In addition, CT showed that the larger and asymmetric aortic valve complex in bicuspid patient. Very severe calcification, sometimes severe calcification, and then asymmetric. It showed very asymmetric sinus, so sometimes it is difficult in the valve implantation. In addition, calcium distribution, calcium volume of in patient with the bicuspid is 2 times higher compared with the tricuspid AS population. So more severe aortic valve calcification. Some calcification patterns, severe calcification, rapid calcification, alveolar calcification increase the peri-procedural risk and long-term risk. So we do not do the too oversized in case with the bicuspid AS, particularly if the calcium volume is very high, more than 10,000. Usually S3 is nominal sizing, or sometimes the undersizing to avoid the complication. In addition, so the aortic valve of bicuspid is larger than tricuspid. We implanted a larger valve compared with the tricuspid. In addition, more frequently we did pre and post dilatation. So this is an instance of procedural complication. P-value is not significant, but numerically compared with the tricuspid, bicuspid patient, numerically the procedural complication is higher. But the echocardiogram follow-up, I told that the larger aortic valve size is so implanted larger valve. The hemodynamically, up to 2-year follow-up, no difference between bicuspid and tricuspid valve. Clinical outcomes, death, stroke, no difference. But considering the younger age, we have to pay attention to the good clinical outcomes. So now, how many we have the available evidence on TAVR in bicuspid AS very limited. So we did a kind of meta-analysis. We assessed the TAVR outcomes, bicuspid versus tricuspid AS for TAVR versus SAVR for bicuspid AS. First issue is TAVR outcomes in bicuspid AS. We enrolled around 6,000 patients. The mean age is 74. Male dominant, STS is 6.7. The balloon expandable, self-extendable, half and half. Moderate, significant parallel leakage occurred in 5%. Permanent pacemaker implantation 12, a little bit high. Altitude injury 0.8. So 30-day mortality 2.1, stroke was 2.3. So how about the bicuspid versus tricuspid AS for TAVR? Two large registry data show that there is no significant difference regarding hard endpoint, mortality or stroke. We enrolled 13,000 patients from 34 studies. So to compare the tricuspid and bicuspid is younger and more male dominant. Look at the procedural complication is significantly more frequent in bicuspid AS TAVR patient. Parallel leakage, risk of significant parallel leakage increased 59%. Permanent pacemaker rate is no difference, but the alternate route injury, 81% increased. Major bleeding is not different. Different from the previous data, we found that small but significant increased patient with bicuspid underwent the TAVR. The mortality is 30 days. Increased risk is 34%, stroke is 27%. Then how about the TAVR versus SAVR for bicuspid aortic valve stenosis? So there is very limited data to compare the TAVR versus SAVR in aortic bicuspid AS. We enrolled 10 studies with 7,000 TAVR patients. To compare the TAVR versus SAVR, age is parallel leakage is higher in TAVR, but bleeding is significantly higher in SAVR, but mortality and stroke rate is no difference. So this is my summary. Available data suggests that the carefully selected patient with a bicuspid AS can do TAVR with the current generation device. Our meta-analysis found increased procedural complication and the risk of mortality and stroke in bicuspid patient, emphasizing need for meticulous patient selection, pre-procedural planning, and post-procedural optimization to ensure favorable outcomes and mitigate risk. Given the younger age of many patients with bicuspid, reducing the rate of pacemaker implantation risk through the improved device implantation technique should be prioritized. It is important to recognize that not all cases of bicuspid are suitable for TAVR, like echo score used for rheumatic MS or scoring system specific to bicuspid AS should be developed to guide the decision between the TAVR and SAVR treatment. Thank you for your attention.
Thank you, Jung-Min. So next talk is going to be given by Dr. Hayashida on RESILIA tissue, why it would improve the lifetime management of all patients.
So thank you very much, Alan. Ladies and gentlemen, I'm very happy to give a lecture in this meeting. So today I'm going to talk about RESILIA tissue, why we improve the lifetime management of all patients. And this is my disclosure. So actually, I was a fellow in Massy, France from 2009 to 2012. And at that time, so we had really bad complication like this. So therefore, the 30-day mortality after TAVI was 20% in 2006. Even in 2009, when I joined Massy, so it was more than 10%. And I really think that it's quite important to decrease the mortality rate and to introduce this technique safely to Asian patients. And I spent 3 years in Massy, and in the last year, we have the very good friend Yusuke Watanabe and Masaya Yamamoto, and we created the database, integrated two-center database, and published some data. However, it's quite important to publish the data as an equal partner from Asia to the world. That's the reason why we started the Ocean SAT family. And we start from the 3 centers. Nowadays, we have 30 centers so far, and we included the more than 22,000 TAVIs, more than 5,000 mitral tears, and appendage closures. And we published more than 150 papers so far, including TAVI and mitral and appendage. And some of the papers are accepted in not only in Japanese guideline, but also in American and European guidelines. And I started my experience with Sapien from Sapien, classical Sapien with 22-24 French. And XT was introduced in our country in 2013. And we started using Sapien 3 in 2016. And in 2023, we started using the S3UR. And we are happy to use the first case of S3UR in our country in the March 2023, and it was a real game changer. And if you look at the way of the sewing of the leaflet, the S3UR provides much better effective orifice area compared to the previous version, especially in 20 and 23 millimeter device. It also equipped with the better sealing scars and higher and much more better textile. And we conducted the comparison between S3UR and S3. This study was conducted by my good friend Masa Yamamoto, and we did propensity matched comparison between S3UR and S3. And if you look at the incidence of severe process-patient mismatch, even with S3, it was 2%. However, it was decreased to 0.5% with S3UR. And S3UR was also associated with a decreased incidence of PVL as well as the mean pressure gradient higher than 20. And the effective orifice area was much better with S3UR compared to S3. And if you look at the breakdown based on the size of the biprosthesis, the incidence of moderate PPM in the 29 millimeter S3 was 8%. However, the moderate PPM in the S3UR in 20 millimeter was 8% with S3UR. That means the S3UR demonstrated very good hemodynamic performance compared to the S3. And we also conducted the SMART-like trial using our Japanese database, and we compared S3UR and Embolic effects in the patient with small annuli. And there was no significant difference in terms of the device success. And in terms of the severe process and patient mismatch, there was no significant difference between two devices. And Embolic was better to decrease the incidence of the mean pressure gradient higher than 20, and Sapien-UR was better to decrease the incidence of the PVL equal or more than mild. And S3 was also better to avoid new permanent pacemaker implantation, and that was really in line with what we experience in our daily practice. And I'd like to show the case example. This is the 93-year female. She received the S3 20 millimeter 7 years ago. However, she developed the structural valve deterioration, and she was so symptomatic. So therefore, we proceed to the TAV in TAV procedure. And this was the S3 20 millimeter, totally the same size as the previous one. Because of the quite high pressure, we did a double tap. And finally, we achieved the no regurgitation at all. And if you look at the pressure gradient, it was only 12 by catheter. However, it was 29 by echo. So we should be careful that there was some significant discordance, especially with the Sapien series with a very small biprosthesis. So in conclusion, ladies and gentlemen, S3UR was associated with better hemodynamic performance compared to S3 in all size variation. And S3UR demonstrated similar PPM, lower pacemaker implantation, and PVL compared to Embolic effects in patients with small aortic annuli. And we are happy to introduce you our meeting, PCR Tokyo Baths. So this year we have the very good meeting, 10th anniversary, with more than 1,200 participants. And next year we're going to have the meeting in February, so you're most welcome to come over to our meeting. Thank you so much for your attention.
So now we have a few minutes to discuss the three presentation we just heard. So maybe just go with David first. So David, with the British Heart Foundation study, how do you think you have changed your practice? And as you know, in the US, there are centers that have been doing like 100% cerebral protection, and there are centers that basically use zero. So I don't know whether you have sort of collected some sort of informal poll whether these centers that do 100%, are they going to still do 100% after the British Heart Foundation study?
So I haven't conducted a poll. I have spoken to Samir Kapadi, who says they're not stopping. So I guess that's one center that's going to continue to use it. I will tell you that my own center, where we do 600 TAVRs a year, and we're using Sentinel in virtually 100% of our cases until the BHF-PROTECT-TAVI trial was released, we have come back, we've pared it back substantially to really selective use now, where we're just using it in the higher risk patients or ones where we perceive that there's a substantial untreated risk. Those kind of patients are bicuspids, very, very heavily calcified valves, or procedures where we're doing laceration of the leaflets. But I think that's still not particularly evidence-based. I mean, I really do think that the key is going to be different devices that hopefully will give us all the benefit that we want, protect all the vessels, and truly reduce stroke. But we've changed our practice substantially, and I expect other centers will as well. Because we saw, even with, even after the publication of the first trial, the US trial, there was a reduction of about 3% of use, and I was just being reminded of it. The use was about, I thought it was around 15% of all cases were getting embolic protection prior to the PROTECTED-TAVR trial. It dropped to about 12%. And I think with this larger trial, it's probably going to drop again, but the only way to find that out is to collect the data.
So David, I have a question too. Oh, sorry.
I was going to ask you.
Okay.
So David, you pointed out very well reasons because these trials failed, and the most important one probably is that we need better device. But once we get them, don't you think that the other strategy would be to select the appropriate cohort of patients, meaning high-risk patients, patients with peripheral artery disease, bicuspid, valve-in-valve, high calcium score, because, to achieve statistical power, you need to have a high rate of events, which you do not have in a general population.
I think that is, if there ever is going to be another clinically powered study, it would behoove the authors and the investigators to try to enrich. And there are two other groups that are not anatomic that are also associated with higher stroke risk pretty consistently in trials. One is women, 2x higher stroke rate in women, and the other is patients with a prior stroke, where it's actually even higher than that. So I think there's enough high-risk patients out there, if we broaden the criteria a little bit more, to do a clinical study. Whether that comes to pass in the United States, I think a lot of companies are going to be very gun-shy, having seen the results of these two trials, and say, if we can get our device approved and we can show benefit on an imaging endpoint, maybe that'll be enough, and we'll just let time take its course and see if a big company happens to buy us, because none of these smaller companies can afford to do a 7,000 patient outcomes trial. But I think it's a good point.
How about just the other panelists? Does it affect if you're using cerebral protection device now, meaning before the study, has it changed your practice?
We in the past, we use 100%, depending on patients who are affordable. But now we are a little more selective, like for the high-risk patients, as mentioned. But still, it's not evidence-based. We don't really have evidence to support us, even for high-risk patients. I was about to suggest that we should run trials on these high-risk patients. With a smaller number, probably we should get a positive result. So
yeah, I think we have to get the good device first.
Yeah.
We have to get.
Yeah. I think the same as Michael. Maybe the same scenario with the thrombectomy device. The trial is negative, but many of us still use it in selected cases. I think we still need it in selected cases, and most of the time you can see that we can catch the debris more than 70–80% of the cases.
Great, thank you, David. Any questions for? Okay. How about for Jung-Min? Anybody has a question about bicuspid? Obviously, he did a lot of, analysis, meta-analysis of the.
I do have some question,
Yeah,
which probably still don't have the answer yet. Do we know which valve platform works better in bicuspid, or do you prefer one versus another? Between below expandable and self-expandable?
Yeah, this is unclear, very, very unresolved issues. Yeah, because of unresolved, why is it unresolved? Our meta-analysis show that 50-50. So 50 patients, our meta-analysis showed that 50 patients treated by balloon expandable, 50 patients treated by self-expandable. I think it is case by case. Because of different characteristics of device, complication is different. So we know that the alternate route injury is higher in the balloon expandable systems. Probable leakage is higher in self-expandable device. So I think we don't have any clear scientific evidence. So we have to select the device based on the artificial complex morphology and calcification volume, et cetera, I think.
So Yeung, congratulations for the presentation. So you were quite positive about TAVI in BFV, in bicuspid aortic valve. So, but the only trial that has randomized patients with bicuspid aortic valve, Notion 2, and it randomized almost 30% patients with bicuspid valve, around 100 patients, actually was negative for TAVI because TAVI had increased risk of stroke, death, and rehospitalization. So how do you comment on that? So do we need further trials? I mean, because we know that there is a fair amount of patients that can do either both, TAVI and aortic valve replacement.
Yeah. This is a very important question. So the Notion 3 trial showed that the bicuspid is associated with a higher risk of procedure and clinical event. So I think I don't like to say that all bicuspid can be treated by the TAVR. But particularly in younger patient, 60 years old or early 70 years old, if a patient, the bicuspid morphology is hostile to the TAVR procedure, for example, calcification volume is very high and very chunk calcification at the LAFE or alveolar calcification, I think this patient can be treated by the TAVR. And otherwise, very low calcification and morphology looks fine for TAVR. Why not? We can do TAVR for this patient.
Any other question for?
Can I ask a question?
Yeah, please.
So thank you very much, Jimmy, for your fantastic lecture. And I'm very much interested in the geographic variety of the incidence of bicuspid valve. For example, the Chinese people have much higher incidence bicuspid valve in the TAVI cohort. On the other hand, our Japanese cohort has only 5% or less than 5% of bicuspid disease. And some people say the Chinese people has tendency, genetic tendency to have bicuspid. On the other hand, I think that there is some substantial difference in terms of the mean age. For example, the mean age of the Chinese TAVI cohort is 70-something. And our mean age still 84, 83. So what do you think is the best, the most important factor to explain the difference in terms of the incidence of the bicuspid valve?
Thank you, Hayashida Sensei. So even the data from the United States, the bicuspid is very frequent. United States data based on the surgical AVR population, the bicuspid is very more than 50% in age between the 60 to 70. But older than 80, bicuspid is very rare. So I think it totally depends on the mean age of the TAVR population. So you are right, the Chinese population is around 74. Your population, I think the oldest population. So the 84 or 85, bicuspid would be very rare.
Thank
Okay, one more question. In our practice, the aortic root dilatation becomes an issue that had a lot of debate. And usually they are in the 80s, 90s with bicuspid and have some dilatation of the aortic root. Do you have a threshold, to which extent you would send them to surgery because of the root dilatation?
Yeah, this is another important question. So for me, so high surgical risk population and older age more than 80, frankly speaking, I don't consider the ascending aorta size. If ascending aorta is more than 6 centimeters or 7 centimeters, I go to. But 5.5 or 4.5 or 5.5, I don't care. But the younger population, we have to care. So I think 5.0 or 5.4 to 5.5 would be the threshold to consider the surgical AVR plus ascending aorta replacement.
I think we talked about a little bit is that besides that its own risk of rupture is also procedural risk. So you have to be careful how the valve is going to deliver even in a 4.5, right? Yeah. Because it could, in terms of angle of entry, calcification. So all those are additional risks that I think you need to pay attention to. So thank you.
Thank you.
Question for Kentaro?
Yeah, I think I have the question. Is Kentaro presentation is excellent. So first day TCTAP, I met the Dr. Kendra, the now CMO in the Medtronic, and she talked to me and the current proportion of TAVR, specific TAVR valve used in US in the sapien valve 70-80%, and the Evolut is 20-30% before SMART trial. But after release of a SMART trial, over proportion of Medtronic is going up to 30 and 40%. The reason why Evolut is much frequently used small annulus. I think Kentaro presentation is very nice, wonderful. I think the clinical impact is so big, and the Asian Pacific is very small annulus, and you show the SMART-like analysis. We concern for me, and if the case requiring the sapien valve 20, I select Evolut 23, 26. So SMART-like your analysis showing the comparable result in the hemodynamic analysis. I have a question to Kentaro. I would like to hear opinion from another panel about we require additional SMART trial using sapien 3 RESILIA, or just that analysis would be okay. Yeah. Kentaro?
Okay. So thank you very much. These are very important question. Actually, the breakdown in our country is 60% Edwards, 30% Medtronic, and 10% Abbott. And we conducted this kind of a SMART-like trial because the result of the SMART trial was no. I wasn't quite sure that it can be applicable to our patient, and. So the result was quite in line with what we experience in the daily practice. And we also need to be careful that there is substantial selection bias, because we usually exclude the patient with LVOT calcification from sapien 3, that we favor the sapien in this comparison. So I think that in the future, maybe we can think about the direct comparison between S3UR and Evolut FX, excluding this kind of the LVOT calcification. That would be much more much fair.
Any panel is Tullio is after release of the SMART trial.
That's really a critical question. But before doing a randomized trial like you are proposing, we have to show that gradient makes a difference. So I would start a new randomized trial when we have enough proof that from a clinical standpoint, having higher residual gradient after the procedure matters for structural valve deterioration and things like that. Otherwise, we are doing trials on numbers and not on clinical events.
And also other issues like coronary access, second valve, all that plays a role in the bigger picture as well. So I think certainly consider it more often, but still other factors play a role, I think, right? So go ahead.
Okay, so we move to the second part. I think the second part is a much practice-changing topic. I'm very pleased to introduce the the last year's the key trial is about the early TAVR trial for asymptomatic AS. I'm very happy to invite the PI of early TAVR trial and the Philip Generux and Philip.
Well, thank you so much again for the kind invitation, and congratulations for the amazing meeting. Great discussion today. And sorry for the one who hear my talk for the 6th time, Alan, but you definitely can give this talk now. But I will discuss the lesson learned from early TAVR trial. This study was published in New England Journal. I really invite you to read the paper and also the appendix. There's so much key point in the appendix. New England is 2,700 words. It's hard to pack everything we had to say, but there's the appendix is so rich in great findings. So early TAVR was by far the largest trial on the topic of severe aortic stenosis with no symptoms, enrolled patient age 65 and above, STS score 10 and above, and LVEF 50 or more. Key point, every patient had a low level, were considered for a low level stress test treadmill to confirm asymptomatic status, which was not done routinely in all the other studies. After that, they had a CT scan to make sure they were suitable for TAVR, and we had a lot of coincidental finding, and we can talk about that. Then after that, when they were suitable for TF-TAVR, S3, Ultra or S3, they were randomized to TF-TAVR or clinical surveillance with a primary endpoint at minimum of 2 years. All patients had 2 years follow-up, composite of all-cause death, stroke, or unplanned cardiovascular hospitalization. So this is one of the first important findings. We screened 1,600 patients between March 2017 and 2021 during COVID. We exclude 43%. And 20% of the patients from the 1,500 were excluded because they already had either symptoms, positive stress test, or a class 1 indication for AVR, either on a CAT scan or the stress test or in questionnaire. So first findings, a lot of patients have already a class 1 indication when they are in the community with severe no symptoms. So please refer them early and see them and do the CAT scan. Second, 15%, 1 out of 6 were excluded because they were not candidate for TAVR. Every patient wants TAVR, but actually if you don't do the CAT scan, you don't know they're not candidate, and actually change the discussion substantially. So we randomized 900 patients, 1-to-1, to either TF-TAVR to clinical surveillance. This is a baseline characteristic, very important. Mean age 76, 30% female, 85% were low risk per heart team, so 15% were high risk or intermediate risk. Treadmill stress test was performed in 90%. Key CCQ score 93, so this is very high, it's better than mine. They were really asymptomatic and happy. And 8 to 9% of the patients were bicuspid, so a very important subgroup that were allowed in the trial. It was high gradient concordant severe AS. There was no low flow, low gradient in this, with a normal EF 67% in average, so very normal and asymptomatic high gradient patient. So the primary endpoint, as you saw earlier, so death, stroke, and unplanned hospitalization was reduced by 50% with a strategy of early TAVR compared to clinical surveillance, and the median follow-up time at 3.8 years, corresponding a number needed to treat of 6 patients only to reduce 1 event at 2 years, which is pretty good. There's no difference in mortality between two groups. We can discuss again why, but the main reason is because the patient in the clinical surveillance group were followed so well, and as soon as they get symptoms, they were treated as a class 1 indication within 3 months. So we didn't let patients die in this trial. We treated them compared to different geography where they follow patients with symptoms. Stroke was non-significant trend in reduction of stroke by early intervention. So 10% stroke in clinical surveillance versus 5% in early TAVR. I can tell you if Sentinel had this result, they will be thrilled. So I think early intervention reduced stroke, and this is something that we can discuss in the future. Unplanned cardiovascular hospitalization, obviously we won mainly because of unplanned cardiovascular reduction, 60%, and we can discuss what type of hospitalization they were in this trial. There is no difference in subgroup analysis, whatever it was the sex, the baseline STS score, able to do stress test or no, or baseline velocity. The early TAVR was beneficial in all those subgroups. So if I had to redo this trial, I would choose this endpoint. It is a non-controversial endpoint, death, stroke, and hospitalization for severe heart failure, which was defined, as you see below, as hospitalization with IV diuresis, inotropic balloon pump, ventilation for pulmonary edema, or hemodialysis. You can see a reduction of 40% in favor of early TAVR compared to clinical surveillance. So I think this is, for me, what will make the study very important. This is buried in the appendix. New England didn't want to put in the main paper, so please read the appendix. There's a lot of great findings. So there's pre-specified secondary endpoint, what was important. So we had early TAVR was associated with a better quality of life and being alive at 2 years compared to clinical surveillance. And the integrate LV-LA health, which is a marker of cardiac damage, what the patient in early TAVR had a better healthy heart, at 2 years compared to clinical surveillance. This is very important. What was the natural history of patients randomized to clinical surveillance? The patients that were randomized to waiting, how did they convert to AVR through time? 26% at 6 months need an AVR, 50% at 1 year need an AVR, and 71% need an AVR at 2 years. I think it's important to tell patients what is the likelihood that they're going to get symptoms through time. The median time to conversion was 11 months. Those results are not surprising. This is exactly the result of Catrinotto or Pelica that they published in 1996 or 2000. This is a natural history of AS when you do a great job following them. The symptoms were as follow: 83% had dyspnea through follow-up, 30% has class 3 or 4 heart failure, so it was not a simple class 2, so 30%. And syncope was 7%. So for me, it's very important, again, to talk to the patient about this. We did a little bit more classification of the way the patient convert to symptom. We divide the patient in 3 groups, whether they present with no symptom. There's only 9 patients in the trial that were converted to AVR with no symptom, mainly class 2A, 2B, mainly patient with cancer, or mainly patient that need a hip replacement, for example, urgently, patient with progressive sign and symptom class 2, or did they crash and burn in acute valve syndrome, AVS, or what we call severe or advanced symptom, class 3 heart failure, or 4 pulmonary edema, syncope, new arrhythmia, drop of AF, etc. And what we saw is that 40% in the waiting group convert with acute valve syndrome, 60% with progressive valve syndrome, and all those patients are class 1 indication for AVR, and only 1 to 2% with no symptoms. The proportion of patients that had acute valve syndrome was consistent through time. So if someone converted within 0 to 6 months, 40% of the time they crash and burn. And that was true for all the follow-up. So really consistent proportion of patients presenting with severe symptoms. And again, if I had to choose another endpoint for this trial, this one made the main paper. Death, stroke, and acute valve syndrome, you show 50% reduction in this event with a much more pleasant curve to see, which is progressive through time. The reason why we didn't see difference in mortality, for the reason is there. The readiness and the promptness of AVR, TAVR, was pristine. If you were randomized to early TAVR, you receive your TAVR in 14 days, which is like remarkable. If you're randomized to waiting and you start to get symptom, you had your TAVR in 32 days. So 90% of the patients that were waiting get their AVR within 3 months of having symptoms, which I think this is something we should achieve in real life, because if you do this, you're going to mitigate mortality of severe AS with symptoms. The other thing is the outcome was spectacular in both groups. You can see cardiovascular death in early TAVR, 0% at 30 days post-TAVR, and 0% in clinical surveillance at crossover. It's hard to show a benefit of mortality with such a great therapy. Same thing with stroke, 0.9 versus 1.8, and pacemakers, 6% versus 8%. So what are my lessons learned for asymptomatic severe AS? I think early referral is the key. If you have severe AS, no symptom, don't wait for symptom and now it become chaotic and you try to do everything in one hospitalization. Don't wait for the acute valve syndrome. Refer, do the CAT scan, and schedule your procedure. 20% of the patient labeled as asymptomatic in the GP office, the general doctor, already had a class 1 indication for AVR. Bring the patient, repeat the echo, and do a CAT scan, and now you talk. 50% will need AVR within a year. 40% will present with crash and burn scenario, so it's not trivial. I think early TAVR, one thing that they prevent unpredictable crossover to significant severe acute valve syndrome. There's no penalty for early intervention. As a matter of fact, it seems that the case is simpler, calcium score is lower, and you probably have less stroke during the procedure because it's easier. So there's no penalty of early intervention. I believe that we were sleeping for so many years that on AS as a risk factor for stroke. I think that prolonged exposure to constant LV load with hypertension, LV hypertension, create AFib, they have more calcium score, and it's a risk factor for stroke. So I think this is a strategy that we need to replace the valve earlier to prevent stroke. If you're not convinced by those data, okay, no problem, but please, if the patient has symptom, prompt AVR will probably mitigate mortality and within 3 months. So don't wait on patient on a waiting list for 6 to 8 months with shortness of breath. People will die and have stroke. So what I said to my patient and referring physician, refer early, get organized and plan early, do the CT scan, fix your teeth, discuss with the patient a date in the calendar. If you wait for symptom, treat promptly, and there's no penalty of early intervention. So I'm going to stop here. Thank you, sir.
Thank you, Phil. The ending of all lecture, we will have discussion time. Okay, second, the lecture is from the James Flaherty. The We Know Well Minimalist TAVR. The topic is the Ultra-Minimalist TAVR procedure.
Thank you very much to the organizers for the invitation to this tremendous meeting. Congratulations on 30 years. Here are my disclosures. So this was TAVR in the early days. All general anesthesia, TE guidance, a lot of transapical, high rates of complications, long lengths of stay in the ICU and in the hospital. It was a big deal when you did TAVR 15 years ago. But it's become a lot more fast and efficient, more experience, better imaging, different techniques, smaller devices, and better planning. And this has led to be more cost effective. We saved a lot on cost by making this an easier procedure, a quicker procedure. And the so-called minimalist TAVR is even more cost effective, saves hospital dollars. The first big breakthrough was CT imaging. When we first started TAVR, we were using just TE to guide size and deployment. CT changed all that with annular sizing and appropriate imaging of the vasculature to allow for percutaneous closure, which was the second big breakthrough, getting rid of surgical cut down and really also decreasing the need for alternative access with closure devices that are very efficient. Conscious sedation has largely replaced general anesthesia, and this has been associated with improved outcomes and shorter hospital stays. And then we've had the emergence of these care pathways, started with the 3M group in Vancouver. We have a bunch of characteristics in planning, and you implement them as a system. And this group found that when they do things systematically to reduce hospital stay, they can get discharge down next day 80% without any cost on quality. And this has been reproduced in other groups in Europe with FAST TAVI-2 trial. You can see that they got their early discharge substantially up in a short amount of time just by introducing these protocols. Here they are. I'll go through some of them in detail. Same thing with the benchmark study group. So the bottom line is you could follow any of these to help develop your own institutional plan on how to do TAVR efficiently and get people in and out quickly and safely. Keys to a short stay: make the clear plan before the case with the patient and the family. Follow best practices to reduce complications such as vascular access and closure, minimal sedation. Avoid program variation. That's very important. You have different operators, but you really want the team to be doing things the same. It prevents confusion and it avoids errors. Have a clear pathway to deal with conduction issues. Early ambulation is associated with a shorter stay. And in institutions that need a pre-discharge echo, get it as soon as possible. Some people do it an hour once they wake up. You have your echo. You don't have to wait for your echo lab to do it the next day. For vascular access, the standard has been to pick one side for the big sheath, and then on the other side, go get venous access for a transvenous pacer and arterial access for a pigtail catheter. This has been the standard for many years. But there's other options on this. Single-sided access is something that I adopt whenever I can. You put the big sheath in the common femoral, and then about a centimeter below it, you put a 5 French sheath after you've done your percloses for your pigtail catheter. It's important to put the pigtail up before you put the biggest sheath in, because it'll get gelled there. But this came out of Cleveland, and it showed that this approach really doesn't, if anything, it reduces vascular complications. It also, more importantly, facilitates getting all sheaths out by the end of the case. It's not for everyone, though. If the artery on the side you're putting the big sheath in is very small or tortuous, this technique might not work. In those cases, we had Dave Cohen show us that cerebral protection is really kind of lost its luster. So you still have, you can save the radial for the pigtail when the femoral is not a good option. And in this cohort, it was associated with substantially less vascular complications using the radial artery as your second access for the pigtail catheter. If somebody has a pacemaker, it's a no-brainer to use the pacemaker with external drive devices rather than inserting a transvenous pacer. And in this analysis, the odds ratio was over 7 for vascular complications using a transvenous pacer when somebody already had their own pacer. And you can see in this group, they've just basically always use it all the time, and we do too. LV pacing, here's an early experience. It's pretty easy. You put a little grounding needle here, and most wires can accommodate this. It's simple. It's really important to be ready to pace before you cross the valve, because sometimes people go into complete heart block or asystole as soon as you cross. So have it all set up with your cathode and anode ready to go before crossing. Here's an algorithm on when to do this. You may want to avoid doing this if it's going to be high risk, like a right bundle or some advanced conduction early, but most cases you can do LV pacing safely and easily. There's some dedicated wires that are being developed. This TAVI wire also does hemodynamics for those that are still getting that information. Here's a list of wires. Almost all wires can do this. Some are better than others, and I think we'll have more dedicated platforms to make this really easy. If you still use a transvenous pacer, this is a trick that came out of the Cleveland Clinic. You pull back the pacemaker at the end of the procedure, and you stick it in the right atrium, and you stepwise pace up to 120. If you go 1-to-1, you have virtually no chance of needing a pacemaker. MCOT, or mobile telemetry, is something we use before and after. If somebody needs a pacemaker, they have bivesicular block and syncopized, get a Holter or an MCOT and get that pacemaker in before the procedure. If you're worried about them after the TAVR, but they don't quite need a pacemaker, you can stick one of these on them and have real-time monitoring. It's very safe, and it can reduce hospital stay. Here's a trial that came out a few weeks ago from the group in Washington, comparing 2 hours versus 4 hours of bed rest after adequate hemostasis with closure devices. In their small group, 2 hours was plenty of bed rest. You can get people up in 2 hours if there's no issues with the closure. Same-day discharge is something that's gotten a little bit of attention in highly selected patients. It can be done safely. I think this is the future. I don't think we're here yet, but we've developed our own algorithm. Because of cost considerations, there's some disincentives to do this, but I think 10 years ago, people weren't doing same-day discharge for PCI. Now it's my standard default is same-day discharge for elective PCI, and I think that'll be true of TAVR. So best practices, pre-procedure. If they need a pacemaker before, just get it in or figure that out. Percutaneous access and closure. You can use devices like IVL to facilitate that. Carotid access, I think, is a great alternative access. They go home the next day. We use the coronary CTA in our TAVR planning CT to decide if they need a cath. It rules out most significant CAD. Do your discharge planning before and figure out those that are eligible for early discharge ahead of time so that the families have expectations set. In the procedure, conscious sedation, avoid extra lines, avoid unnecessary balloon valvuloplasty. Consider a aortogram at the end instead of an echo in the procedure. Use pre-existing pacemaker, consider LV pacing, optimize in-implant depth to avoid conduction injury, and remove all sheaths before the end of the procedure. Post-procedure, if they're going to need a pacemaker, do it the same day, contact your EP college. The ICU should almost never be needed anymore. Short bed rest and early ambulation, pre-discharge echo on the same day of the procedure, and consider an MCOT or mobile monitoring to send them home early if you're still worried about conduction. So conclusion, TAVR, especially from the TF route, is a routine outpatient procedure. Pre-TAVR planning and inter-procedure techniques have improved safety and dramatically reduced hospital stays. Next day discharge is probably now the standard. In select patients, you can even consider same-day discharge. And most importantly, institute your own best practices and care pathways to make TAVR efficient and safe. Thank you.
Thank you, James. So we move to the last speaker and my friend Tullio Palmerini about this is a real issue in the valve-in-valve procedure. What are contemporary problems?
So thank you, DK. So thank you for inviting me to this amazing meeting. My disclosure, these are the current problems with valve-in-valve procedure: coronary obstruction, patient prosthesis mismatch, sutureless and stentless valve, valve-related embolic debris and stroke, durability, antithrombotic therapy, safety and efficacy of TAVI versus reduced surgery. Coronary obstruction, we have two main mechanisms in native aortic valve stenosis that we can extrapolate to valve-in-valve. The first one is sinus insufficiency, meaning leaflet displaced toward coronary ostia, and we have two risk factors for that: coronary height and sinus-valsalva width. And then we have sinus sequestration, meaning leaflet seals at STJ, and we have two factors for this kind of obstruction, again, coronary height and then STJ height and width. To this, we have to add a specific mechanism for a specific evaluation for valve-in-valve procedure, which is VTC, which is the distance between the virtual valve and the coronary ostia. So you combine all these variables and you get the vivid classification in which you have 6 possible scenarios at different risk of coronary obstruction. But I've said before, coronary obstruction evaluation is a multi-parameter assessment, and for valve-in-valve procedure, there is another variable you should consider, which is the relationship between the coaxiality of the valve and the capacity of the aortic root, such that you can have 3 scenarios: coaxial aligned bioprosthesis in capacious aortic root. In this situation, the risk of coronary obstruction is virtually 0. But then you may have 2 situations: either the valve is tilted towards the coronary ostia in a capacious aortic root, or you have a coaxial aligned bioprosthesis in non-capacious root, and in these 2 situations, the risk of coronary obstruction may be substantial. How are you going to address this issue? Angiography may help you implementing the 1-2 technique, in which you align to post, and you're going to be in a perpendicular view, in a view which is perpendicular to the takeoff of the coronary arteries. Then you draw a line from the most lateral part of the valve, perpendicular to the sewing ring, and lateral to this line, you assess this space, which is the risky space for coronary obstruction. So let's see this case. This is left coronary. Height was 4 millimeter, VTC 4.2. The right coronary was 6, VTC was 5.2. But then you see at the angiography is pretty reassuring, because, we implemented the 1-2 technique. You see that the valve is tilted opposite to the coronary ostia, and actually this is the space, and you have enough space and you don't need coronary protection here. And so we implanted the sapien valve, and you see that there were no issue for coronary protection. If you need to protect coronary artery, there are 2 techniques, chimney stenting, basilica, which have been described in 2 relatively large observational studies. This technique have their own advantages and disadvantages, have been recently compared in observational studies. So to cut a long story short, at the moment, it's just a question of operator preference. My opinion is that we need a technique. The optimal technique will be the one in which, in some way, causes leaflet modification. In my opinion, very promising device is the shortcut device. Patient prosthesis mismatch, is it relevant? Yes, it is, but here to look at large registry, STS, TVT, more than 60,000 patients and severe PPM
was a risk factor for mortality. How to minimize PPM? Optimal implantation, meaning high implant, which should be at least 90% aortic, 10% ventricular, wherein lower implant than that are not, which may be acceptable in native aortic valve stenosis, are not acceptable in this situation. Use supra-annular valve, vivid registry. They have consistently lower mean gradient, and use balloon fracture. Balloon fracture, you need a non-compliant balloon, atlas or true balloon, 1 millimeter greater than the ID of the surgical aortic valve. For the evolute, you have to place this balloon below the commissure, otherwise you run the risk to destroy the commissure, which are at the restrained part of the valve. Start the inflation with a 50 cc syringe, then open the stopcock to the indeflator and start to inflate with indeflator. And you will realize that you have balloon fracture when you have a dropping in the pressure. Sometimes you can see the fracture at the angioscopy. Sometimes you can even hear a sound when you break the valve. Not all the valves, you cannot break all the valves. For example, trifecta, Hancock, you cannot break. And if you are going to do balloon fracture, you have to reassess the risk of coronary obstruction because you are going to change the anatomy. Timing is very important. Performing balloon fracture after TAVI is associated with a better outcomes and a better hemodynamic. Stentless and sutureless valve in the vivid registry, rates of malposition were as high as 50%, and this is due to difficulty in reconstructing the anatomy of the basal ring, difficulty in identifying radiographic and anatomic landmark for THV implant and to define the landing zone, and because sometimes we have no good anchoring on the non-compliant Dacron ring. So let's see, for example, this case was a BioValsalva 25 millimeter conduit. You see, it's very difficult to understand where is the virtual basal ring. And then you see that at 6 millimeter, the tube is heavily constrained by this circumferential calcification, and you have very calcified leaflet and highly degenerated conduit. So these are the measure where we think is the virtual basal ring for 450 area, perimeter 77, but if we go up 6 millimeter, now the area is 254 and the perimeter is 57. No? So we have a double challenge in this situation, so which valve and the sizing of the valve. You see that angiography do not help you very much because you are not able to find a landmark point. The only thing we know from CT scan is that the circumferential calcification is at least 6 millimeter above the annular plane. So in this case, our planning was to put a sentinel for cerebral protection because the conduit was heavily degenerated, and to use an Evolute FX 23 millimeter because we sized the valve at the level where you had the highest constriction of the conduit, like a sizing in a volcano-shaped bicuspid valve. This is the Evolute FX crossing the aortic arch. And you see that also finding the right projection was not that easy. This is what I call a simil-cusp overlap view, meaning what we believe should have been the cusp overlap view. And we had the impression, you see, this was the circumferential calcification, and our target was to be at least 7-8 millimeter below. Then we switched to the simil tricusp view. Also in this projection, we were pretty 5 at 3 millimeters. So we released the valve, and actually the result was good with no paravalvular leak, and the gradient was 5 millimeter of mercury, mean gradient. So let's see this quickly, this other case, 72 years old man, AVR with Perceval Plus. 4 days post-surgery, he had severe aortic insufficiency, and this was the reason. So there was a severe enfolding of the Perceval valve. Of course, now there's no way in which you are going to expand back this valve, so but the only thing you can do is to try to crush this enfolding against the vessel wall to seal the aortic at this level and therefore resolve the paravalvular leak. And I think you have no choice in this situation other than using a sapien valve. But this is a Perceval plus XL, so it would require a sapien 29, but probably it was too big, and this is the reason why you had this unfolding. So the valve, probably there was a mistake in selection of the valve. So inside, these are the measured area 309, but we tried to reconstruct the virtual basal ring below, and at this point, the area was around 500, so we selected a sapien 26. You see also by angioscopy, the infolding is really dramatic. We also have to do this this rotation to be sure that you didn't go through the frame of the valve. So this is the deployment of the sapien aiming at 0. Very slow deployment, just to guarantee stability of the valve. And you see that after valve deployment, we were not able to resolve the infolding, but we expected that, but on the other hand, there was no leak anymore. So in conclusion, valve-in-valve TAVR is a safe and effective procedure to manage surgical bioprosthesis failure. The risk of coronary obstruction can be managed with chimney stenting, basilica, or shortcut device. Patient prosthesis mismatch can be mitigated with optimal position, choice of supraannular valve, or with balloon valve fracture. Long-term valve durability and the optimal antithrombotic regimen remains unclear and need further investigation. RCT may be needed in selected patients in the range of age between 70 and 80 years old. Thank you.
Thank you, Tullio. So we have, I think, enough discussion time. And first, we're going to discuss in depth about, one of landmark trial is EARLY-TAVR trial. I think this is a revisited TCT rate breaking trial. So, and a lot of questions from the panel or audience and yeah.
Oh yeah, Philip. So I mean, this is the 12th time I hear your presentation.
We have enough
but,
time.
I mean, I have to tell you, it's always amazing. It's always a great presentation. So my question is about stroke. So we heard David Cohen saying that stroke has remained constant through years at a range of 2.23%. But in your trial, it is 0.9%. Okay, if I remember correctly the number. So can you explain why it was much lower than what reported in the other trial? Was patient selection, or can you explain something about that?
Yeah, so I think multiple factor. I would say this is a trial also where we have neurologists and we were looking for stroke. So the stroke rate in trial is always higher than TVT registry, which is underreported. So the stroke was very low. I strongly believe there's multiple factors. First, the calcium score of those valves is probably lower. They come with no symptoms. It's not like they have symptoms for 2-3 years. So first, the calcium score is low. Second, we were in part of a trial. We probably are optimize our technique or implants, et cetera, et cetera. The reality is when you look at the stroke rate in the early TAVR group was 0.9, and then as follow-up, the clinical surveillance was 2%. And we had CT scan data that showed that the calcium score progressed from 1,000, for example, in 1 year to 2,000 or 3,000. So this is where I came with the idea of acute valve syndrome. So I think those patients, to intervene early with less calcium score, but also stable, where the patient is not inflamed, is way, way better than wait for an acute valve syndrome presentation where you have more calcium score, you're maybe more inflamed, something happens, so the patient progress, and also crash and burn is suboptimal, longer length of stay, et cetera, et cetera. So also the AFib was less in the early TAVR group. There was less new onset AFib. So I think all those factors, I think for me the best option to prevent stroke in AS patient as a disease state is to go early. We're going to see this result if it's true with moderate AS, okay, with the progress trial, which is done with calcium score of 600. But just to give you an idea, in TAVR on load, which was a study from moderate AS with heart failure, the stroke rate was 0.2 in the early, or 0.4 in early intervention, compared to 1.4 in delayed treatment. So I think there's something there. Early is probably a stroke prevention technique. Yeah.
I have a question.
So,
in early TAVR trial, patients initially assigned to the clinical surveillance group, more than 30% received the conversion to the AVR. Is there any predictor, the early conversion to AVR?
Yeah, so we present the ACC, the acute valve syndrome, and we look for risk factor for acute valve syndrome presentation and also early presentation. So early presentation and also acute valve syndrome was the incapacity to do a stress test. So 10% of the patient was unable to walk on a treadmill for orthopedic issues. So those were more likely to convert early or to convert in crash and burn scenario. Probably they were symptomatic. If you cannot walk, you either diminish or symptomatic. Then after that, PVD, patient with peripheral vascular disease. Again, they're more diminished. They don't have vascular reserve. They cannot increase their blood pressure because of stiff vessel. So I think they're also more vulnerable. And the other one, I think, was a large left atrium, which is probably a surrogate for AFib, and the stroke volume, which is lower, maybe, et cetera, et cetera. So there is predictor. That said, the C statistic was 0.6, was very poor. So the model was not very good to discriminate who convert early or not. So I don't think I would put too much weight on this, because there's also a lot of patients that were completely normal with KCSQ normal stress test, young, and they crash and burn within 3 months. So I think this model was very poor discrimination.
In our practice, for completely asymptomatic patient, we don't see them, coming back with symptoms and require valve replacement like 25% within a month, and all of them within a year. Do you think that partly because they participate in a trial and then, being randomized in a so-called conservative arm? And my second question is, repeat hospitalization requiring a valve replacement is part of the methodology of the conservative arm. Why should that be counted as an endpoint? Mm-hmm. Delay AVR is part of the protocol, but it's also being counted as an endpoint. So why don't we just use death? If you have delay AVR, would it result in a different death rate?
So I would precise a few things. So there's a lot of confusion with the primary endpoint. That's why we run alternative endpoint, death, stroke, heart failure, death, stroke, AVS. The primary endpoint was death, stroke, unplanned cardiovascular hospitalization. The only time we consider AVR, conversion to AVR, as a primary endpoint was only for the first 6 months. Only for the first 6 months. After 6 months, it's not counted, okay? Unplanned was if you crash and burn in the hospital, you go to the ER, so there's a long definition of what unplanned was. It was clearly unplanned. For the first 6 months, we choose this because we sat with the guideline. We said the guideline recommend AVR, clinical follow-up within 6 to 12 months. So we took the longest. So if you sit with your patient and you say, okay, I see you in 6 months, you're good, and the guy come back in 3 months with pulmonary edema, the guideline failed this patient. So that was the rationale. So not all AVR through the trial was considered, only the first 6 months. So, but just to say that 40% of those AVR were real severe symptom, or pulmonary edema, syncope, etc. So even if you, the 26% that converted within 6 months, if you take 40% of that, let's say it's 12% patient or something like that, we still dominate the trial. And this is why the alternative endpoint of death, stroke, AVS, or death, stroke, heart failure make the study very robust. But obviously people look at the endpoint and like to see the flaw, but we didn't trick the trial. We decided on this endpoint 7 years ago, and it's, the perception is we tricked the trial, and it's fine, I respect that, but we should also look at all the other endpoints we derive from this and the lesson learned, because it's still a very robust trial. The conversion to symptoms, the first 6 months, this is what people don't like. But when you look at the Catrinotto or Pedica paper, at 2 years, we have the exact same rate of conversion. Lanceloti paper, 2 years, it's 70%. But they don't like the velocity the first 6 months. And the patient will follow very, very well. So we will never be criticized that the follow-up was not good. If we had shown a benefit of mortality, okay, people will say you didn't follow them, we should follow them earlier. But you can follow a patient every day, you're still going to miss conversion to symptoms. If you see the patient in the morning, the patient gets pulmonary edema at night, you're going to miss it. So that's the concept.
So I think, the key problem is, Alan, you might be agree, and the key problem is early TAVR trial is a two-sided of a sword. And my feeling is that if TAVR durability guaranteed 100% more than 20 years, early implantation is the answer. But the durability is limited. But if they put the later time, we expected irreversible cardiac damage. So this is some dilemma. Asymptomatic patients and no pulmonary edema, BNP is normal. It's 72-year-old, put the valve. It's a long-term durability we should consider. Yeah, it's how
consider that conversion was within 1 year, so you don't lose time in terms of durability because patient, correct me if I'm wrong, Philippe, so patients are going to be on TAVI or on surgery within 1 year, majority of patients. Is that right, Philippe?
Yeah, so this is exactly what we say. So this argument become irrelevant that you start the clock of bioprosthetic valve degeneration. The natural history showed that within 2 years, the vast majority will need a valve. So for example, if you're 65, people have a hard time with the young people. If you're 65 or 70 years old, you're going to need 15 years. Let's say best case scenario, 15 years, you're going to need another valve. You're still going to need another valve if you wait 2 years. Okay? You're not going to change the fact that the patient will need 2 valves. It's very rare, actually, that you're going to have a scenario that will be altered. So that the natural history dictate, and actually the cost of waiting, and I'm coming with new data in a couple of weeks, that will show that the cost of waiting is stroke, and is money, and is mortality eventually. So I think it's only 2 years follow-up. We have to wait 5 and 10 years, and we're going to see maybe that the cost of cardiac damage is real.
So Philip, very quick question. If a totally asymptomatic patient comes to you saying, I want TAVR, would you do it?
With severe as no symptoms?
Yes, of course.
Yeah,
no
so
symptoms.
Yeah, absolutely. So definitely. So right now what I do a CT scan, okay?
Yes.
And this is where being a doctor is important. It's clinical judgment. Right. If you have a 75-year-old good patient, severe as CT scan suitable for TAVR, yes, of course, because you're going to need within 1 and 2 years. If the patient is 96 years old, okay, she's content with her quality of life, I do the CAT scan, it's an alternative access, risk of stroke, I said, you know what, I see you in 6 months. And when you need it, I do it. So again, it's dependent on the patient. It's still the same shared decision-making process of if you have symptoms. I think symptoms become irrelevant. And if you're more SAVR, if you're more surgery, let's go surgery. For me, it's early referral and timely AVR, whether it's TAVR or surgery. So that's, yeah.
So I think part of the reason is that we have been stuck in the original way of thinking that you need to have symptoms and you have to have 40mm 40, right? So when we approach a patient, I typically ask symptoms first. The reason is that if I talk about the valve first, then they start to worry about whether they really have symptoms. So I think we need to just change our approach to our patient. It's really talking about how bad the valve is.
Yeah.
Forget about the symptoms and then talk about symptoms later.
Absolutely. I think we're one step too far. So I think the discussion of symptom is for moderate. Okay, so I think severe with symptom versus severe no symptom, you already too far. I mean, this is irrelevant because 1 to 2 years you're going to need it. So I think the real discussion will start with moderate. Let's see progress trial and they expand to. But I think we need to reset one category to the before. All the guidelines will change one category to the left, and that will be fine. Yeah.
And which is one comment I talked before, because the surgeons never have to ask that question. The surgeons see the valve is tight. They don't care whether the symptoms or not. They're on the operating schedule for next week.
Absolutely. That's too late for asking for symptoms, right?
Well, I always said that in the OR is a black box. You don't even know what's happening there, and symptoms are irrelevant. So surgeons are very innovative and forward-thinking. They were doing this for years, so we should follow their guidance.
Thank you,
Philippe.
Okay, we move to the second topic. Is about
sorry, DW, just one question.
Karl,
so,
yeah.
do you think we need a similar trial for surgical bioprosthesis? Because some of my sickest patients tend to come in with this acute valve syndrome, such as Percival valve. They just come in crash and burning. You know, your Vmax was 3. Next day it's regurgitation, or they have other issues. I know it's been life-consuming, your trial. Do you think there needs to be a trial for bioprosthetic failure?
So that's a very good question. I never thought about that, actually. That's a very, very important question. That's not a bad idea. Let's think. Let's talk about it.
Great. Thank you, handsome guy. Okay, we move to the second topic. Is the minimalist TAVR approach. And James, any comment? Or is my first question, how much minimalize it? You know, you guys, any same-day discharge TAVR procedure? No?
Next day.
Next day.
Next day. Yeah.
Okay, could you comment and any
Same,
question to the...
same day's coming. It's not here yet for most, but you'll see. In 5-10 years, it will be like PCI. You know, we weren't doing same day for PCI 10 years ago, but now we do it routinely.
But for Chinese Asians, we always see this oozing from the groin 4-6 hours after they sit out. So sometimes it might be a little worrying.
We routinely use protamine. I didn't include that in my presentation, but protamine and good closure devices typically minimize that.
Well. Yeah.
I think all depends on your inpatient cost and inpatient, accessibility. If you have, 3,000 beds in your hospital and they're staying 6 days waiting for, a PCI, and a day or so or more is not. So I think the systems.
The health system definitely dictates what you can do and what you should do. In fact, if you do same-day discharge in the U.S., you may pay a financial price because it's an observational and it's billed at a different level. So some of that matters too.
How often do you put this patient on the outpatient monitor?
But, I see it used about 5 to 10% of the time. After the first day, assuming nothing bad has happened, it's all about the conduction issues.
Right.
So if there's no clear indication for pacemaker, but you're still worried, I think a lot of people feel comfortable with those devices to catch, the MCOT, just to review, it catches stuff in real time and it gives you a call and lets you know, and just for a safety issue, a patient can come in and you can check it out. And
we experience, especially for the evolute valve and 5 days later, 6 days later, patient developed the syncope and revisited emergency room. And James, do you use some smartphone or any device for detect late occurring the arrhythmia?
We use the MCOT, which is, it's a dedicated Holter device, that event monitor, that through a company will contact you if any significant heart block or arrhythmia is detected while the patient is wearing it. It doesn't have to be patient triggered.
I would like to ask about your take on minimalism in the alternative access population. So in the high volume center, minimalism is pretty standard for transfemoral in a lot of centers, but for alternative access, a lot of operators still don't want to leave the comfort zone of GA femoral access, but I've been able to have the opportunity to look at the result of about 30 cases of minimalistic alternative access TAVR, and I think it's feasible. And there might be advantage in doing this. For example, the Achilles heel of the transcaval access is sometimes the secondary 8 French sheath in the other leg. But you can, if the aorta is small, 16 millimeter, you can actually, even if you need a cover stand, it can be put in through the left radial. And if the aorta is 22 millimeters, you can use an 8 French sheath from the radial access to oppose with a 22 millimeter balloon. And similarly, for the transaxillary access, we found that if the patient is awake, we know about the neurological event during the same procedure, even though there might be disadvantage of pain. So what is your take on
I think institutionally, you pick your favorite alternative access, and as a team, you get good at it and develop a system of care. For us, that's been carotid. Carotid is, the only downside of carotid is typically it's going to require general anesthesia. But those patients go home the next day. It's a minimal incision. It's a quick procedure. So to my opinion, whatever alternative access your institution can master as a team is going to lead to predictable results, whether it's transcaval or percutaneous transaxillary. But you don't want to be doing those once or twice a year. So there has to be a cadence so that everyone is comfortable with that.
Thank you very much. So very nice lecture. So I want to ask a question about what time the patient comes to a hospital and the end is end of the when the patient go back to their home.
We typically have them arrive 2 hours before the procedure.
2 hours before.
And, you know, we try to get the echo done. We always have an echo done outside of the operating room to reassess the gradient and look for any leak. We like to do that in the same day. And then they can go home, you know, whenever they're convenient the next morning. So a lot of times their stay is a little more than 24 hours.
Very quick question. Do you use always conscious sedation in your minimalist approach, or you have a proportion of patients treated just with local anesthesia? For example, in our practice, 85% of patients get just local anesthesia, not even mild conscious sedation.
We use conscious sedation. It's the same we use for PCI. It's just our standard. You could get away with it in certain cases, but our practice is conscious sedation, and you know they're awake after the procedure. I don't think it causes a delay.
Thank you, James. So we move to the last topic about the valve-in-valve procedure. Any question to the Tullio? So, and the Tullio is, okay, Jung-Hee. Yeah.
Thank you for a nice lecture. If patients require the balloon fracture in valve procedure, before TAVI or post-TAVI balloon fracture is effective?
So thank you for this question. This has been a very long debate. Okay, so we have felt that doing balloon fracture after the procedure would be safe. But now, I mean, there are also some data from a big registry, okay? And even though it's not a randomized trial, this data suggests that it's better to do the fracture after the procedure because it's safer and you get a better hemodynamic. So again, it's not a randomized trial. These are the only data we have, but again, our practice was this way even before.
So my question to the panelists, I would like some last question about how do you do, you know, a coronary rescue? There are three options: is a chimney stenting, and the basilica, and the shortcut. Shortcut, I heard $35,000. I'm gonna never use it. So, you know, how do you feel in the, you know, Kentaro and the Shinichi and the Karl, and in your practice, you do frequently do basilica technique? I think it's very difficult. Yeah.
So in Japan, there's the basilica, and then furthermore shortcut is not approved, and we usually do the chimney techniques, but some surgeons scolded us because of the chimney technique is the worst for surgeons. So recently, the doctor from running outside Japan teach us about how to do the basilica. So gradually increasing the number of the basilica.
Tullio, do you have a...
Yes, well, actually, if a patient is a candidate for surgery and you need to do coronary protection, we send to surgery. No question about that. So if he's not a candidate for surgery, we use chimney because that means that it's unlikely that you're going to need to re-engage the coronary artery with this patient because this is the only drawback of chimney, okay? So it's going to be very difficult to re-engage the coronary artery.
I think to that point, if you need to do double basilica, it's probably way off and surgery should be reconsidered. If it's unilateral basilica, I do that, I'm sure. Others would, and maybe chimney on the other side if it's not. But I think bilateral, the data is pretty poor to do bilateral basilica. We don't have access to the 15,000 US shortcut, despite asking for it many times. But I think surgery should be emphasized, still an option, isn't it?
So the thing that I don't like of basilica is not that it's difficult, but it's unpredictable. So you do basilica and still you run the risk to occlude the coronary artery. So you have done a very complex procedure and you're not even sure at the end that the coronary is not going to get closed.
Okay,
Yeah, so I just want to say it's not 35,000, it's only 15,000. So just to reassure you, so I know it's still a lot.
It's a tariff.
It's a tariff because of the tariff.
25% tariff.
Yeah, exactly. But I will say that the place, Shortcut is a game changer. I use it routinely now, and especially for dual splitting. So dual splitting is very complex. We start to use unicorn a lot before Shortcut. So, you traverse the leaflet with an S-tattoo wire and you bring a small balloon and then a bigger balloon. So you literally explode the leaflet, but there's potentially for brain issues. So I would say that the Shortcut will not end up at $15,000. Right now it's a strategy. So Shortcut device, they charge $15,000. Eventually it's going to be reimbursed in 2 years with a very high reimbursement, and then they're going to reduce the price. This is always the same little dance with reimbursement. But I will say that it's a game changer for at least dual splitting, where you don't have a great
Next year, TCTAP, we're going to in-depth discuss Shortcut.
Happy to do so.
Yeah. It's the last question.
Anyone has experience in the hybrid technique for bileaflet modification? I mean, for the left cuts, you can do a basilica. It's pretty straightforward. You get a nice split midline shift. The problem with the unicorn is you don't have directional control, and the calcium chunk can sometimes get into the opposite side. But for the right cuts, if you do a basilica, sometimes you can still end up with coronary obstruction. And there are experts that say that you need balloon augmentation anyway when you do the right cuts. So I've been exploring the hybrid technique to do left cuts basilica, right cuts unicorn. This has the advantage of reducing the procedure time, reducing the number of overlapping catheters, and simplifying the access. So I wonder what the panelists think about this.
I think for valve-in-valve, you really need to have a good CT study, meaning a lot of times, I think you did a case that is, people still keep saying you may not have coronary obstruction. And if you go to bilateral doing a lot of things, you might end up with strokes and other things. So I'm not saying you don't need it, but you just have to be very good in analysis and also doing, probably some virtual valve implantation and see what it is exactly, because, meaning that you don't want to be doing 25% of these with bilateral coronary modification, leaflet modification.
Okay, and we have a very nice in-depth discussion, and we're going to close this session and then move to the last live case demonstration from Asan Medical Center. Thank you, everyone.